and I'll do our intro. Perfect. Thank you so much. So welcome everyone. This is the mental health assessment for young children, brief billing overview. We're going to go over a couple housekeeping slides. While we do that, please feel free to enter your name, your organization, and your role in the chat just to orient us to who's joining us for today. This is another reminder that we are recording this webinar today. You should have gotten a pop-up just now, and if you don't feel comfortable staying with us as we record, you can leave the meeting. Otherwise, please feel free to stay off camera if that feels more comfortable, or drop things in the chat to Kiki if you'd like to remain anonymous, and we are happy to accommodate those requests. We just like to have this recorded so that we can upload it to our webpage for folks who aren't able to join us and take time today to be with us. I'm Christine Cole. I'm the Infant and Early Childhood Mental Health Program Manager here at the Healthcare Authority. That just means that I focus on our policies and programs for kiddos birth to 5 and those who care for them. And I am one of 2 members of our Infant and Early Childhood Mental Health team. I will let Kiki introduce herself.
Morning, everybody, or I guess it's afternoon. Thanks for being here on your lunch break. I'm Kiki, also work at the Healthcare Authority. And if you have any technical issues, you can send me a message in the chat. And if I'm looking over at my screen, that means I'm just reading the chat messages.
Awesome. Thanks, Kiki. We wanted to give a quick overview about today's webinar, just so folks have an understanding of what to expect and what not to expect. Today is just a brief overview. So this is just us, going over some of policy changes that happened related to mental health assessment for young children. The intended audience is, of course, mental health clinicians, but we're super excited to see that we have billing and coding staff joining us today, as well as agency leadership. We also wanted to share that we have some other resources on our webpage that you can access, such as the slides from today. We'll upload the recording, and then it also has information about where to access billing guides and things like that. You can also sign up for our prenatal to 25 listserv. This is a way in which you can get updates from us as we do things. I will just clarify before we go into anything else that this is not a training on like clinical documentation, like what to include in your progress notes to justify what you're putting in your billing claims. And this does not get into details about scope of practice. This is specifically about billing and coding. And so you are certainly welcome to share those questions, and Kiki and I can keep track of those to follow up with folks, but just want to make sure we appropriately level set what you'll get out of your time with us today. We also wanted to just give you a quick orientation to using Zoom. So if you have any questions, you're welcome to put those in the chat. Kiki does a really good job of interrupting me to make sure that we capture what you all are needing to know and getting clarifying information. You can also do the raise hand emoji if you'd like to come off mute and ask the question. We ask that folks stay muted. We are super interested in your participation. We just ask for muting so that there's no background noise. If folks can't hear us, it can make it challenging. You can also use the live transcript if you'd like to have closed captioning on the bottom of your screen. And if you need any support, Kiki is available and able to assist in any way. So we're going to get started. Kiki, is there anything else you want to add before I jump into content? Awesome. Just as a starting place, we wanted to just acknowledge that some folks might not be familiar with the terminology or even who the Healthcare Authority is. We at the Healthcare Authority are purchasers of insurance, which, whoa, so sorry, everybody, that we oversee the Medicaid program, which is called Apple Health here in Washington. And that's just the coverage that is then administered through our managed care organizations and then for our Medicaid without a managed care plan. We also oversee behavioral health care programs, and we also oversee public and school employee benefits. So that means that folks like Kiki and I that work for the state, and then school employees, that Washington's Healthcare Authority also oversees their benefits packages. We also wanted to just orient folks before we jump into deeper content that when we think about the Apple Health Medicaid behavioral health system, we acknowledge that we are just one small piece of this really big network of overlapping and interconnected services and requirements and providers. And so just wanted to acknowledge that there's different components of the work that are governed by different authorities, such as Department of Health is our the folks who do our licensing and credentialing for mental health professionals, as well as a lot of others. There's a lot of different funding streams, so we certainly certainly oversee the Medicaid funding and some of the like state and federal like block grants and things like that. But there's also additional funding streams that are offered, like the Department of Child and Youth Services. Child and Family Services, sorry everybody, has like child welfare funding that sometimes is utilized to pay for things that aren't covered by other entities. And we also just wanted to acknowledge that multiple changes have happened over the last few years. And so sometimes there's pieces that we're still getting caught up on. And so we just do all this to acknowledge that the information we might be sharing, you might be trying to get caught up on how does this fit with these other pieces. Kiki, is there anything you would add? Awesome. Sorry, everyone, for my tech issues today with clicking. We also, I mentioned there's managed care in our state, and so we just want to do a quick orientation for folks who may or may not be familiar. Fee for service, which also is considered Apple Health coverage without a managed care plan, is when HCA provides payment directly to providers. There's a contract that we would have with providers to do this. A lot of times, the folks who are on our fee for service plans are either folks who have not yet gotten assigned to their managed care organization, that it might be folks who are American Indian or Alaskan Native who have an option to opt out of managed care, or also our kiddos and families who might be undocumented are sometimes covered through our fee for service plans. Then we have managed care plans, which is basically we have contracts with 5 different managed care organizations that you see listed on the screen. And this is really a model that's intended to help with delivery system organization, to manage costs and utilization and quality. And so our managed care partners do a lot of other stuff to support offering care to kiddos and families across Washington state. And so in that situation, we actually pay MCOs to go do the work, and then they contract directly with providers. And so sometimes they have additional guidance. And so we just wanted to note this, that if you are contracted with a managed care organization, we encourage you to check in with their provider services to make sure you're following their policies and procedures, because they start from what we give, but sometimes they have some additional details. And now into the good stuff. So the mental health assessment for young children. So work in this area has been happening for a really long time, both in our state, but also nationally. And part of this is because approximately 10 to 14% of children birth through 5 years old experience an emotional, relational, or behavioral disturbance. And if these disorders are identified using developmentally appropriate criteria, they can be effectively treated. And when that happens, then it allows us to have appropriate services that then can reduce long-term impacts, either by the diagnosis could go away completely, or by mitigating some of the severity or intensity of the needs. Our current systems, like the DSM, which stands for the Diagnostic Statistical Manual of Mental Disorders, that it doesn't adequately address these developmental needs. So it was really created with adults in mind, and they've been doing a lot of work trying to adjust it and make it more appropriate for children, but it still doesn't adequately address the relational and developmental needs that we're really thinking about when we're thinking of kiddos birth through age 5. So for this reason, there were a group of folks that were brought together from an organization called 0 to 3, which is a national organization. They brought together researchers and practitioners, and they worked together to kind of look at practice and research around what would a diagnostic tool look like for kiddos birth to 5. And what they came up with is the diagnostic classification of mental, it's always so long, Kiki, of mental health and developmental disorders of infancy and early childhood, which we all call the DC 0 to 5 because it's a mouthful. And this tool is developed specifically with kiddos birth to 5 in mind. We have this light green part over here to really highlight that the DC 0 to 5, even though it's a tool for diagnosis, they also talk about an approach to diagnosing. And so they really encourage that you start from a cultural and community context, which you'll see on the very far side. And that's really saying that as you go through this whole process, we want to be making sure that we're checking in on how are these things interpreted and what meaning comes from that culture and community's perspective, rather than applying our perspective from our own culture and community. And it encourages folks to go through these different axes. So it looks at development, what might be going on. Are they meeting developmental milestones? Are there potential delays in this area that might explain what's going on? They look at life circumstances. Sometimes we talk about that as like stressors or context. So are there things going on that might help us to understand what's happening? They go into medical conditions. So, really valuing us making sure that we are checking in with medical providers to make sure we're ruling out any potential medical conditions or issues in that area that could be contributing. And then a really important piece is that we look at relationships. So, what's going on with the primary relationships for this kiddo that might help us to make sense of what the needs are and what supports might be needed, what challenges might be going on. And we look at all of that before we then look at whether or not there's a mental health diagnosis. And that's really important because we want to make sure we're ruling out other things and not moving kiddos and families into mental health treatment that might actually have need early intervention or might benefit from some sort of medical treatment or something like that. Once we've looked at all of that and we're saying, yes, I think we've got some sort of mental health, behavioral health concern going on, then they provide a developmentally specific criteria and diagnoses for this age group. And so the first kind of set is that we might have diagnoses that are similar to what we see in adults, but they have criteria that tells us how that might show up for a 3-year-old instead of an adult. And then they also have a couple other disorders that we don't have at all in our DSM or in our adult systems that typically present in childhood, like what you see here, overactivity disorder of toddlerhood, or also something like excessive crying disorder. And so I'm going to pause for a second. Kiki, are there any questions before I switch to the next slide?
So far, no questions in the chat, but if there are any, please send them in and I
Okay,
will give us a pause.
awesome. Thanks, Kiki. And so this group pulled together this manual as well as this training to say these are the things that we actually think accurately represent and capture what's going on for young children when we're thinking about their development and their mental health needs. And so, for that reason, last year in the 2021 legislation, a group from the Children and Youth Behavioral Health Work Group, which is a legislatively mandated group, advocated for legislation that then passed. That is Second Substitute House Bill 1325, Section 211, that Kiki and I lovingly now refer to as MACI, which just stands for Mental Health Assessment for Young Children. And so, what this did is it allowed us to shift to best practices for young children that include multiple assessment sessions, being able to offer these sessions in the home and community, and then utilizing the DC 0 to 5. And I'm actually going to just switch to the next slide because I think it's more helpful and easy to digest about what this means. And so for us, what this meant, it specifically mandated that Apple Health, so Medicaid, make these changes. And so we always highlight that that does not apply to private commercial insurers. This is specific to Medicaid. And what it did is it allowed us to change our rules around the initial intake assessments. So sometimes these are called like psychological evaluations or diagnostic evaluations or intake assessments. So us allowing that to be up to 5 sessions, it mandated us to come up with a way to pay providers for doing their assessments in home and community. Again, it has us use the DC 0 to 5, which had 2 parts to it. It had us create a crosswalk, which we'll talk more about what that is. And then it also had us start offering trainings for mental health providers and allied professionals so that they know how to do this approach and how to use the tool. So we're going to go more in depth on each of these items, starting with our multi-session assessments. And we intentionally call it multi-session assessments because you're not required to do 5 sessions. It's just that the limit that is in place is up to 5 sessions. And so we'll talk a little bit about what that means. So the policy itself says that Apple Health, Medicaid, mental health providers conducting health assessment for children from birth through age 5 will be eligible for reimbursement for up to 5 sessions for the purposes of assessment. And we also added the per client, per provider, per calendar year, which I'm sure those of you who are familiar with our billing guides are used to those kinds of terms. I'm sure all of you recognize after we had gone through all the different pieces that folks are supposed to be considering when they're assessing utilizing the DC 0 to 5, why you might need multiple assessment sessions to consider development and medical needs and life stressors and all the different pieces. And so it's really that these sessions are intended to help folks to be able to meet with the family to gather history, to gather documents around what else is going on, and to observe interactions for them to be able to get all of that information to be able to arrive at a diagnosis. It's important to note that this did not make changes to the codes that folks should be using when they're capturing on their claims or their encounters. So folks will still use the same CPT and HCPC codes, which we're going to touch on the next slide. So we wanted to share all of this information together because, like we talked about, how there's a lot of different pieces outside of just the HCA around this work. There's also different ways that this work plays out within the HCA's guidance. And so infant and early childhood mental health services could be taking place in private practice. It could be happening in licensed behavioral health agencies. It could be happening in primary care. And so this policy applies across the board for those who are providing mental health services to children birth to 5. But whatever billing guide or service encounter reporting instructions you are already using, you're going to still use that same tool. We have actually updated and have specific language in these tools around mental health assessment for young children. The biggest piece to note is that it's pretty much the same in terms of which codes you would use, except when we think about our mental health billing guide part 1, which relates to more of our what we call the physical health benefit part of Medicaid. H0031 is not a code that's allowable for these purposes and that guide. Broadly, if you are someone that was already using the mental health billing guide, either part 1 or part 2, you will keep using it. And what you do is you will just use the code for each of the sessions. So if you do 3 sessions, you're going to use the same code 3 times. For the service encounter reporting instructions, if you already have been using this tool, which is largely used by our licensed behavioral health agencies, you'll still use the same code, but you're going to use the 53 modifier. And that will be for you'll use that for all of your sessions until your last one where you have all the information you need, and then you'll take off the modifier. And basically what this does is it tells us, I still don't have all the information I have yet. And then once you have all the information you need, you stop using the modifier because it says, I'm done, I've completed my assessment, and we're ready to move forward. All of these codes, you're still expected to use the same coding standards from the CPT guidance in terms of how to document and demonstrate that you are doing what you need to do in your sessions. I'm going to pause for one quick second, Kiki, just to see if you have anything to add.
Just want to note that we got 2 very interesting questions in the chat, but I think it will be helpful to go through the rest of the slides on this section, and then we can get to your question, Sally and Lorena.
Awesome. So you'll notice we are adding something about limitation extension. One of the questions that we had very early on was like, what if I start with a kiddo and they turn 6 next month and I'm not done yet? Or what if a kiddo came in and we used up 3 of their sessions and then life happened and they discontinued treatment, but then they came back later in the year and I only have 2 sessions, but I actually need 3 sessions to get everything that I need. You are able to use a limitation extension, which is a form of prior authorization. And so basically you would just submit it indicating this is why I need more time to gather what I need. I will note, because of early periodic screening, diagnosis, and treatment rules and laws from our federal Medicaid that we follow in our state, you technically can also do this for a kiddo who is older than age 6 if you are needing more time to say medically, in order to demonstrate the information I need to reach diagnosis, it's medically necessary that I have additional time to gather the information I need. Kiki, is there anything you'd add to this piece? Okay. We also wanted to share that we got questions from folks about like, well, when I'm doing my first session, if I need more information, it feels weird for me to put a diagnosis on that claim saying that it's something if I need more time. And so federal Medicaid guidance requires the use of the International Classification of Disease Codes, and the current version is ICD-10. And so that is something that is required on claims and encounters to be able to say, this is the problem that we're addressing with this service we're offering. For the purposes of these 5 sessions, we are encouraging folks that when you are saying, I don't have enough information yet, that you can utilize the F99 mental disorder not otherwise specified. That basically is saying, we don't know what it is yet, or we can't diagnose it yet, which makes sense if we're saying we need more time. When you get to the final session, that could be session 3, that could be session 5, depending on what's clinically appropriate. And that would be up to you as the clinician working with the family to see if you have the information you need. You would then update the diagnosis to the most appropriate F code series. So currently our F code series is what we utilize and think about for our mental health services. And so you would update it using the Apple Health DC 0 to 5 crosswalk, which we'll talk a little bit more about later in these slides. It's important to note that even though we're providing the crosswalk and even though we're saying these are the codes that you can utilize when you're doing treatment, this does not mean that this is within your scope of practice. Professionals are still expected to follow guidance from the Department of Health around their licensing credentials, from their own professional associations, and from what their own supervision training and experience they feel is appropriate for them to be doing. And so if something is outside of the scope of your work, we do not think you should be doing that. This doesn't say go out and do all those things. It's just giving guidance from a billing perspective of what's allowable from a reimbursement standpoint. Key, is there anything else you'd add for this one?
I don't think so.
Okay. This is the last piece for the assessment component. So if you have questions, we can do that now.
Sure. So I'm going to scroll back up to Lorena's question, which was, what if the client has private insurance and Medicaid? They'll have to complete the assessment. So there's kind of a couple pieces to that. One is to remember that Medicaid is the payer of last resort. So you're always going to want to bill for private insurance before you bill for Medicaid. But if they still have Medicaid, if there's things that the private insurer doesn't cover, but Medicaid does, Medicaid will cover those services. So if your private insurer won't cover multiple assessment sessions, Medicaid does, that's what you can bill to us.
Yeah,
Is
and I
that
would
what
just
you'd say,
add,
Christine?
yeah, I would just add that you'll have to demonstrate that the private insurer is not paying for it. So you would have to submit it and have the denial for the additional sessions, and then you can submit those to Medicaid for us to reimburse. That's how it works when you have secondary insurance. If someone has private insurance and does not have Medicaid at all, that does not apply.
Lorena, does that answer your question? I'm going to assume yes, hearing nothing, but please feel free to unmute or put in the chat if there's additional clarification you'd like. Oh, she says wait. Okay.
Okay, sorry, I was trying to unmute and I couldn't find it. Okay, so I understand that Medicaid is the second option if private insurance doesn't pay. But there are times that we do, like private insurance doesn't cover the copay, and so then we do that. My question is, do we still have to do assessments for Medicaid, or if the private insurance isn't requiring that we do this assessment, do we have to do this?
I think I understand, Lorena. So us allowing up to 5 sessions is not us directing providers on how many sessions to use. Clinicians should still be using their clinical judgment around if they're able to capture the information that they need. So no one is required to do 5 sessions. The guidance is that folks have the flexibility to use up to that many sessions, but they should still follow their best clinical practice. In terms of what folks should or shouldn't do in terms of their private insurance, we can't really direct them on what they should be doing. If they don't feel like they have the information they need, then there are certainly workarounds that providers utilize to get the information that they need. So I can't speak for private insurance, but from a Medicaid perspective, we're not saying you have to do that many sessions. Clinicians should still do what's best in terms of what information they're gathering and what else they still need to arrive at a diagnosis. It's just that they're allowed to use up to 5. Does that help?
Yeah, that helps.
Okay.
And that's great. Because in the past, I felt like I needed more information, but if I submitted a 90791, it was, rejected or denied. So I couldn't really do anything about it. But now I know that at least this way, if there is Medicaid, then I can do it that way. Otherwise, well, private insurance isn't going to pay, and that's final. But thank you.
Yeah, of course. Thanks. Good question.
And then we had another question from Sally that I'm going to scroll up to read that says, are providers able to provide any other type of service in the midst of these 5 sessions or however many sessions it takes? For example, a quick 15-minute collateral call to a daycare provider without having to use the assessment code, possibly H2015. And I'll share one piece of context, which is that one of the requirements to provide mental health services is to first do that intake. And the reason for that is to make sure that there is the information that's needed to create a treatment plan, understanding what's going on with a child, what's going on with the family, before really diving into services. But I think your question is a good one, and understandably why you might be thinking about others that are happening, especially if this takes a while. It could be a month or even longer to do those 5 sessions. So my guess is that we'll want to go back to some of our billing experts and ask them about this. But Christine, do you have any thoughts about this question?
Nope, I think you covered it, Kiki. Sally, I think that that's a nuanced question that we have not yet gotten. And so we just want to make sure that we double check before we give a more specific answer. But the broad answer is that in terms of services, it would be after you've established medical necessity through the diagnosis like Kiki was talking about, but let us double check.
Okay, thank you. Yeah, it's come across a couple times. Our staff, want to get the collateral information to complete the maybe developmental portion of how they are at school, but the phone calls or they don't really want to waste a whole assessment, one of their 5, right? If it's just like a 15-minute call, it's like, can we do only a 15-minute one, or should we be using something else? I mean, it makes sense to be able to, it's part of the eval, but it ends up just being a short one, I guess. But I just wanted to double check.
Yeah. And Sally, like I'm sure you as well as everyone on this call knows, you of course can call people if you have a release of information. It's just the billing part we'll have to get back to you on.
Yeah.
Of course, you all can talk to collaterals. It's more of us just giving you additional guidance on how to code that.
How to code it. Exactly. Okay. Thank you.
Yeah. Thanks.
And Madeline, your question is it might feel a little separate, but it's very aligned. Like if for doing a 90791 or 90, like you're doing the assessment, can you bill when you're talking to collaterals like a childcare provider? So it's a great question, and Christine and I will follow up and provide some info, unless there's a piece that I'm forgetting, Christine.
I would just say for folks, for those of you, whether you're a coder or you're familiar with infant and early childhood mental health practices, there certainly are times where it's helpful to have a caregiver only session. And we are currently working on developing more clear guidance. And so we'll have some information at the end about how to continue to get updates, but we will be providing further guidance around caregiver only sessions. Kiki and I have just been talking about childcare providers. Typically, when we're talking about caregiver only, we're talking about caregivers or guardians, not necessarily, other providers. And so the other providers part kind of falls more into Sally's question. And so we will follow up on that part. And we are currently in process of developing guidance for folks on how many sessions, what's appropriate for caregiver only sessions. These are all really good questions.
Great questions. Yeah. And Cassandra, I see your question about the crosswalk, and we will definitely get to that. So you're prompting us almost perfectly.
Awesome. I'm going to keep going. We're going to talk about some provider travel, and love the questions. Please keep them coming. And please feel free to drop your information in the chat if you want to have any more specific pieces as we figure things out, but that we didn't capture in those answers so far. So provider travel policy, the language from the legislation is that Apple Health Medicaid mental health professionals providing mental health assessment to children birth through age 5 will be eligible for reimbursement for provider travel to home and community settings for mental health assessment sessions. And so similar to what we were just talking about the up to 5 sessions, this is not a requirement. Folks are not required to go to home and community settings. We also acknowledge that not every child and family will necessitate travel to the home and community. And so this isn't to tell people where to do their sessions. It's only to be a support for if folks are doing the sessions in home and community settings. Providers should still be talking to families about families' preferences. They should be using clinical judgment around what feels like they're getting the best information that they need, and also thinking about safety concerns, agency policies, and things like that. We will be sharing a little bit more on the next slide about kind of how we're going about this, but wanted to just acknowledge that Kiki and I are also in process of looking at like what might additional supports need to look like for agencies that are figuring out how do we actually put this into practice. Like, sure, you're telling us that you would pay for it, but like there's pieces that we have to figure out logistically on how to do that. And so that is a future iteration that we don't have specific answers right now, but if you'd be interested in connecting with us, again, welcome you putting your information in the chat because we will be reaching out to folks to talk more about this soon. And so for provider travel reimbursement, providers or agencies are able to submit an A19 invoice for travel reimbursement. And this is based off from the Office of Financial Management mileage rates, which is updated, I think, semi-annually to annually. And so they update those. It's a standard statewide process that happens. In order to get this invoice, folks have to have some eligibility criteria that would be associated with the claim to make sure it's appropriate for this reimbursement. So the first one is this is only applicable to mental health assessment. So those service codes we already talked about, 90791, 90792, and H0031. If you're using any other code, those will not be eligible because this is only for the intake assessment component of treatment at this time. We'll also be looking at the client's age through their Provider 1 number because this is only applicable for children birth through age 5 at this time. And so if you're over 6, then we won't be able to do the travel reimbursement part. And then the last part is the place of service. And so this would just help us to know that you went somewhere and that you weren't just sitting at your office. And so that helps us to know that you actually did the service someplace other than where you typically work. The submission process is slightly different if you're doing fee-for-service versus managed care. For fee-for-service, those would be submitted directly to the HCA, and we would then process those and pay the providers or agency. For managed care, folks are going to submit those to our managed care organizations. Then the managed care organizations pay you all, but then they send us information about that too. We will note that I think something that's really exciting for this project is that we know that sometimes things are different for different managed care organizations, and they all have adopted a very similar form and the same process in terms of submission. You should have the same general experience in terms of how it plays out, regardless of which plan you're working with. So we just wanted to share, this is what the form kind of looks like from HCA. The managed care organizations ones should look pretty similar. And you can go to our mental health assessment for young children webpage to access this form. Kiki, are there any travel reimbursement questions?
Not yet.
Awesome. I will keep going then.
I have a quick question, if you don't mind.
Yeah.
So it looks like from this that the miles are reimbursable, but the time isn't necessarily. Is that accurate?
That is accurate, Louisa. So
Okay.
this is currently based on mileage being reimbursed. It is not provider time.
Okay.
Yeah.
Thank you.
Which we know is not necessarily compensating commensurate to the time and the productivity lost for providers. But that is a good clarifying question.
Yeah. It wasn't the answer I had my fingers crossed for, but I was expecting it. So thank you.
Thank you. All right. So the DC 0 to 5 requirement, this is primarily looking at like right now how we can support the field in meeting this requirement. We're going to talk about two different pieces. We're going to start with talking a little bit about some training components and the different resources available, and then we'll get to that crosswalk question that folks have. So the policy says Apple Health Medicaid mental health professionals conducting a mental health assessment for a child birth through age 5 are required 0 to 5. We've gotten a lot of questions about like, what does this mean? When am I required to do this? Does this mean I have to go to the training? And so currently we are, as HCA, interpreting the intent of this legislation to be supporting the field and moving in this direction in terms of using the DC 0 to 5 as the standard and expected best practice when we're working with children birth through 5. Currently, what that means for us is that we are working on building up workforce capacity to support this legislation. And we're doing that in two ways. One is through offering training so folks know about this tool and how to use it. And then also us developing a resource called the Crosswalk to help folks in being able to take what they're doing and make it work for our Medicaid billing system. At this time, we do not have like a specific date or a specific way in which there would be some sort of oversight or tracking of like the requirements, but we anticipate as we continue to build up knowledge about this in the field, that the workforce and others will help us to have clearer ideas about what an implementation date and what a requirement might look like from more of an oversight or a monitoring kind of perspective. At this time, we don't of any of that going on. We are certainly gathering information as we are implementing, and I'm just going to put a plug that we're going to be sending out a feedback kind of survey about how implementation is going. And if you have thoughts about what would be supportive or helpful in this area, in terms of meeting the requirement, we encourage you to participate in that survey so that we can really know what this might look like for the field and what the field would want this. I'm going to keep going. Kiki, do you? Okay. So resources to support the DC 0 to 5, there's kind of some different ways that this is happening. And so this green box here is really to elevate the work that falls under mental health assessment for young children, which is Kiki and I administering through the HCA. And so this is really looking at like sustainability and infrastructure needs, like we said, connecting with agencies to say, what are your challenges? Like, what else might you need? What other guidance can we develop? We'll continue to hold the pieces around billing and contracting and those kinds of supports. And then we also hold the kind of development of the crosswalk. You might have in some of our messaging or in different places, things about this infant and early childhood mental health workforce collaborative, which is being coordinated by the Washington Association for Infant Mental Health, otherwise known as WAIM. WAIM was awarded the contract for this work after doing a competitive solicitation. And really their role is in coordinating the trainings and the supports for professional development around diagnosis and assessment for providers. And so they're doing DC 0 to 5 clinical trainings, which are longer trainings for mental health professionals that are doing the diagnosing. It really goes into like, these are all the axes. This is what you need to be doing a thorough assessment to get what you need to arrive at a diagnosis. They're also doing overview trainings for allied professionals, which we've defined really broadly, but this is really for folks who are either touching the lives of children and families birth to 5 or are working with mental health providers who are working with kiddos birth to 5, like coders, like leadership, on kind of getting some like basic foundational understanding of what is the DC 0 to 5, what does it include, why are we using it, just to be informed in your work with either children and families or with mental health professionals. They're also doing a little bit additional support around professional development resources to really help with like putting it into practice. So acknowledging that going to one training doesn't mean that you have all the things that you need. And so offering just additional supports for like, how might I apply this and operationalize it in practice? Are there any questions about kind of how those are both separated?
No questions in the chat yet. Just add that we know that some of you who are here today have either attended the clinical training or the overview training. So if you want to share with folks how that training was helpful or not helpful for you in the chat, we'd love to hear from you. And these trainings are all free right now, running through June of next year. So we highly encourage folks who do have the time to make use of these free resources.
Awesome. Thanks, Kiki. So the DC 0 to 5 crosswalk, a crosswalk is really a reference tool for mental health clinicians that helps to convert or translate DC 0 to 5 diagnoses into the associated ICD diagnostic codes or DSM diagnoses. Many regions have created their own specific crosswalks to reflect what's usable in their state. And the reasons that we need a DC 0 to 5 crosswalk for providers is really a couple different pieces. So one, Centers for Medicaid and Medicare Services, I flip those around, but CMS is our federal Medicaid agency, and they require ICD codes for reimbursement for services. And so that's why they have it and then we have it for us to be able to communicate, like, these are the things that we're seeing that we're providing services to address. We also know that a lot of different agencies have electronic record systems or electronic medical records that include, like, folks type in, they've programmed it that they just type in the DSM diagnosis, and then that does some sort of magic on the back end to turn that into an ICD code. And so acknowledging that for some folks, they might not have a way to just enter the ICD or the DC 0 to 5. It's also worth noting that in the DC 0 to 5 manual, it does include a sample crosswalk, but the publishers reference it as a sample because they are not updating it every time ICD-10 codes are updated. And they also recognize that different states have different policies and rules around what codes are turned on or are usable in their states. And so for that reason, that's why us developing a crosswalk is really an important tool for supporting providers in practice. And so just for some orientation about, like, how to use the tool, the first part is that you'll do the assessment. So like we've been talking about, you'll use those up to 5 sessions. Again, it could be 2 sessions, 4 sessions, 5 sessions to really gather all the information that you would need. Then you would take that information and look at the symptoms and the pieces that are expressed in the DC 0 to 5 manual and identify what clinical disorder feels appropriate. And then you would use the crosswalk to really then move over and say, okay, social anxiety disorder. If I need to enter a DSM diagnosis, I would input social anxiety disorder. That one's pretty easy. It's pretty close. Or this is the associated ICD classification, social phobia unspecified. Clinicians, it's not a tool for, like, clinical practice. It is just a reference guide for billing purposes. So this is not to say you have to, like, give kids these diagnoses. Folks should still use their clinical practice to assess and use the DC 0 to 5 to identify the appropriate diagnosis. This is just how you can put it onto your claims or encounters to make it reimbursable for Medicaid purposes. If you want to check out our current version of the crosswalk, you can access it on our webpage, or Kiki might have already put it in the chat. We are in the process of updating our crosswalk. So Kiki and I based the current interim crosswalk off from what other states have done and just updated places where things were not billable because either because of our policies or because ICD-10 had been updated. But the intent of the work for this legislation was really that there would be a community-informed crosswalk. And so for that reason, we've been meeting with a group of individuals since February of earlier this year, and we've been really looking at our crosswalk to make sure that we have a lens of what's appropriate from our Washington providers. And so we anticipate that in fall, winter, we'll be publishing that for folks, and folks can start to reference that tool. Kiki, any questions on this piece? Okay. And so we're getting to the end here. We just wanted to share with all of you that we have a short feedback form that Kiki will share that we would love to hear from you on what was helpful, what was not helpful. And then we also, again, wanted to just put a plug that we're doing an implementation survey in September. And this will be looking at all the pieces that we talked about today to say, did you know about this? Which hopefully all of you here will say that you did know about it. How is it going? What is implementation looking like for you and your organization? And what barriers and challenges might you be facing so that we can kind of start that work on what might be supportive for next steps for all of you and for making it a reality. Kiki, is there anything you'd add to this slide?
Just so that folks know, the feedback form for today's webinar, I just put in the chat, should take you less than a minute. The survey that we're planning to send out in September will be a little bit longer just because we really do want to understand how this is working and what else we can do to support you. So stay tuned for that to come out soon.
Thanks, Kiki. We also just always like to highlight that there's different ways to hear from us and to get information about what's going on. We will post these slides on our webpage, which I'm sure Kiki has blasted you all with the webpage multiple times today, but you'll be able to access the information that we have published, to sign up for alerts. We encourage you to come to our office hours. This is often the place that when we get questions that we can't answer, like what Sally asked today, that we usually share at those office hours what we've learned, and then we also incorporate it into future billing webinars and billing guidance. And so we will be updating when we have additional billing webinars, and we will likely be sending out any alerts for changes. So one of these ways, come to one of these things if you want to get answers to any of the questions that you posed. And then we also just have links for all of the resources that are represented here in our presentation. And we also include some different infant and early childhood mental health and DC 0 to 5 materials for folks to be able to access. I know that for some folks, this is a new area of learning for either yourself or for maybe your agency. And so these can be useful tools to share with leadership, with colleagues, with other staff. But the rest of our time today, we have just to answer your questions. If folks have any, I will stop sharing my screen, but happy to pull things back up if needed.
And Christine, just so you know, there's no additional questions in the chat yet, but we covered a lot of information today. And so it could be that you're processing, you're digesting. So if questions are bubbling up for you, feel free to come off mute or put them in the chat, and we will be hanging out here till 1 o'clock.
I just have a quick comment. I went to hit the link for that 1-minute feedback form and it takes you to some weird site that wants you to type in some certificate, and then it takes you to some other government website about typing something in. So
No.
I'm not
All right.
sure.
Thank you, Sally. Let me go check that out.
I'm wondering, Kiki, while you work on that, I'm going to just drop my email in the chat, and I can also add Kiki's. Our feedback form is basically like, how was today? Did you have questions? Did any questions not get answered? And so feel free to also just email us if you feel strongly about it. We would love to hear, to make sure we can keep updating these. We found that these questions that you all ask us and the things that you all talk to us about are really helpful in us changing and updating the webinar, but also our billing guides and things like that to make sure that they're specific enough for what you all are needing in practice.
Okay, I clicked a button that says enable public access. So I think that might be the problem. So I'm going to repost the link to that short 1-minute survey in the chat in case people tried it and it didn't work.
We don't have any questions so far. I'm going to ask Kia to stop the recording for us. Kiki and I will still stay here for the next little bit if there